Hello and welcome to my presentation on Brexpiprazole Augmentation for treatment-resistant depression. My name is Marilyn-Joy MOPALSKY, and I'm a registered nurse and a master's student in the Psychiatric Mental Health Nurse Practitioner Program here at the University of St. Augustine for Health Sciences. I chose this topic because treatment-resistant depression is one of the most challenging situations in mental health care for both patients and providers. In this presentation, I'll share the practice problem, my PICO question, the evidence supporting Brexpiprazole augmentation, and the plan for implementing and evaluating this change, and finally, how we might share those results with a wider audience. According to the Cleveland Clinic, treatment-resistant depression affects up to 30% of patients with depression, meaning they haven't improved after at least 2 adequate trials of antidepressants. Treatment-resistant depression, or TRD, carries a heavy burden with higher suicide risk, more frequent hospitalizations, and major impacts on quality of life and healthcare costs. Because effective options are limited once first-line medications fail, clinicians need safe, evidence-based strategies for augmentation to bring relief to these patients. Here's the PICO question that guided my entire project. In adult patients with treatment-resistant depression, how does Brexpiprazole augmentation compared with standard antidepressant switching strategies affect depression symptom remission rates within 12 weeks of treatment initiation? This clear question provided the framework for my literature search and guided the way I evaluated and synthesized the evidence. To gather the best evidence, I used University of St. Augustine Library Portal, which connects to several databases like PubMed, CINAHL, Medline, and PsycInfo. I focused on high-quality studies, specifically randomized control trials and systematic reviews, published in the last 5 years and involving adults with treatment-resistant depression. I excluded studies that looked at conditions like schizophrenia, bipolar disorder, or treatments like ketamine or electroconvulsive therapy so that the findings would stay focused on Brexpiprazole's role in depression. Across the 8 core studies I reviewed, including randomized control trials and systematic reviews, Brexpiprazole consistently improved depressive symptoms and remission rates in adults with treatment-resistant depression. The evidence points to an optimal dose of 1 to 2 milligrams per day for the best balance of effectiveness and tolerability, with mild akathisia and weight gain as the most common side effects. Supporting reviews by El Hussein and Bal, Caverno and Mangano, and Garcia and colleagues add valuable context, showing how Brexpiprazole augmentation fits within the broader range of treatment strategies for TRD. The strength of evidence for Brexpiprazole is impressive. Much of it comes from randomized control trials and systematic reviews, which are level 1 and level 2 evidence. Multiple studies back this up, from post hoc analyses by McIntyre and Kapadia to Mock's real-world findings in Singapore. Even newer genomic work by Wang and colleagues hints that TRD care will get even more personalized, while Hori's dose-finding study and Zhang's cost-effectiveness analysis round out the picture. Using the Johns Hopkins model, the overall body of evidence earns a B grade, meaning that it's moderate to high quality, consistent, and supports this change with confidence. For this project, I envisioned an outpatient psychiatric clinic as the setting. The team would include psychiatrists, psychiatric mental health nurse practitioners, nurses, and a psychiatric pharmacist, all working together to treat adults with treatment-resistant depression. This setting offers the right mix of resources and oversight. Prescribers who can make medication changes, nurses who can educate and monitor patients, and access to lab work and follow-up appointments. It's also a familiar environment for patients, which helps reduce the anxiety of trying something new. All of this makes it an ideal place to introduce and monitor Brexpiprazole augmentation because it supports collaboration, education, and careful follow-up. To guide the practice change, I chose Rogers Diffusion of Innovation model because it explains not just what to change, but how new ideas take hold within a professional community. Rogers describes 5 stages, from building knowledge to persuasion, decision, implementation, and confirmation, and also reminds us that different people adopt change at different speeds, from innovators and early adapters to the more cautious late majority and laggards. The first 3 stages of Rogers' model starts with knowledge. That means more than just handing out articles. It's about actively educating staff through in-service sessions, sharing summaries of the latest studies, and making sure everyone understands the scope of treatment-resistant depression and the evidence behind Brexpiprazole. Then comes persuasion, using that foundation to share data in a way that resonates, answering questions honestly, addressing concerns about safety and cost, and even highlighting success stories from similar clinics that have used the strategy. Finally, the decision stage, where innovators and early adapters step up. At this point, they're ready to commit to piloting Brexpiprazole prescribing for appropriate patients, helping the team to see that this change isn't just theoretical, it's something we can put into practice. After those early stages, the team moves to implementation. This is where the change becomes real. Brexpiprazole augmentation would roll out in a pilot phase, using clear protocols for who qualifies, how doses are started, and what follow-up should look like. During this phase, close monitoring is key, tracking patient responses, side effects, and feedback from prescribers to fine-tune the process. Then comes confirmation, essentially the stage where we prove the change works. This is where data from PHQ-9 scores, patient reports, and staff experiences come together, and where we start sharing those results in team meetings. Reinforcing the wins helps early adopters feel supported and reassures the more hesitant providers, showing them that this practice change is safe, effective, and worth embracing long term. Rogers also highlights that people adopt new ideas at different speeds. In this clinic, the innovators might be the psychiatric pharmacist and a few psychiatrists who are comfortable using atypical antipsychotics. The early adopters would include psychiatric mental health nurse practitioners who are eager for new tools for their TRD patients. As these champions gain experience, their success stories would reassure the early majority, while the laggards might need more time and more proof before feeling comfortable. To see if this practice change is working, we'd focus on clear, measurable outcomes. The primary outcome would be remission of depressive symptoms measured by the Patient Health Questionnaire 9, or PHQ-9, which is a validated and easy-to-use tool. We'd also look at secondary outcomes like medication adherence, side effects, and whether hospitalizations decrease. All of this would be evaluated within the 12-week timeline set by the PICOT question. For data collection, we'd gather PHQ-9 scores, that's the Patient Health Questionnaire 9, at baseline, again at 4 weeks, and then at 12 weeks to capture early changes as well as longer-term progress. Alongside the PHQ-9, we'd include simple medication adherence checks and structured side effect reports so that we're not only tracking symptom improvement, but also safety and tolerability. This information would come from a combination of chart audits and brief patient self-reports, giving us both objective data and the patient's perspective. Once collected, the data would be analyzed, comparing pre and post scores and looking for trends over time, which would allow us not just to see whether brexpiprazole is effective, but how meaningful those improvements are in everyday clinical care. Once we have results, the next step is sharing them. At the institutional level, that might mean presenting at a staff meeting or even at grand rounds to show colleagues how brexpiprazole is working for our TRD patients. On a local or regional level, we could share findings at a state nurse practitioner conference or with a mental health coalition. And at the national level, a poster for the American Psychiatric Nurses Association or even a journal article would spread those lessons more widely. Research on dissemination from classic work by Corrigan and colleagues remind us that sharing isn't just dumping data. We have to package the evidence so that it's usable, educate providers directly, and address team dynamics so that the change takes hold. And newer work, like Ross Hellauer's 10 Simple Rules, remind us to think creatively, using visual tools, open access, and even social media so that the message reaches as many people as possible in a way that sticks. In conclusion, the evidence strongly supports brexpiprazole as an effective and generally well-tolerated augmentation strategy for adults with treatment-resistant depression. Using Rogers Diffusion of Innovation model provides a clear, step-by-step way to guide adoption, and pairing that with a structured evaluation and dissemination plan helps to ensure that change takes root and reaches beyond one clinic. Working through this project also reminded me why evidence-based practice matters. It isn't just about finding the research, it's about turning that research into meaningful change for real patients. This process gave me a new appreciation for how much thought and collaboration goes into implementing a single change, and how important it is for us nurses and future NPs to bridge the gap between studies and practice. Thank you so much for listening to my presentation.